The diagnosis of dementia with Lewy bodies requires the presence of dementia. This is tested through a low MoCA test or a Montreal Cognitive Assessment Score, and 2 of 4 of additional core features. Number 1, Parkinsonism. Number 2, fluctuating cognition. Number 3, rapid eye movement sleep disorder, and visual hallucinations. Parkinsonism is limb rigidity most of the time. In fluctuating cognition, the patient will describe themselves having good days and bad days. For rapid eye movement sleep behavior disorder, it is a parasomnia characterized by dream enactment behavior. When patients have dream enactment behavior, they usually have a loss of normal REM sleep atonia. Having loss of REM sleep atonia is a common and very early symptom in dream enactment behavior of dementia with Lewy bodies. Alongside the fluctuating cognition that I mentioned earlier, remember that patients may also have early deficits in executive function. For example, they may need more help paying their bills or going shopping. They may also have visual spatial ability loss. They may also lose executive function for visual spatial ability. For example, sometimes patients can be seen lost inside their own neighborhoods. Depression also is very common in these patients and normally will happen at some point of the illness. Pharmacologically, look for sensitivity to neuroleptic medication. Neuroleptic medication causes severe Parkinsonism in these patients, hallucinations, and sometimes even loss of consciousness. Lewy body dementia is an alpha-synucleinopathy, so macroscopically, you will see cerebral atrophy, especially in the frontal lobes, and you will have sparing of the hippocampus. Unfortunately, there's no symptomatic therapy available, but you do have supportive therapy to offer patients behavioral therapy as well and physical therapy. For pharmacology, their Parkinsonian symptoms can be treated with Parkinson's disease treatment. Their dementia symptoms can be analogous to treatment for major cognitive disorders, and if the patient is having psychotic symptoms, you can give them low-potency second-generation antipsychotics such as quetiapine, and the reason why we don't give typical antipsychotics because this may precipitate or even worsen existing Parkinsonian symptoms in patients, especially with Lewy body dementia. More specifically, these patients with Lewy body dementia have an increased risk for life-threatening akinetic crisis when undergoing antipsychotic treatment. Unfortunately, the prognosis is poor and the median survival is around 10 years after diagnosis. Alzheimer's disease typically is presented with early and prominent memory loss, but it won't have these core features of Lewy body dementia like Parkinsonism or rapid eye movement sleep behavior disorder. CJD or Creutzfeldt-Jakob disease is a very rare prion disease that can also cause rapid progressive dementia, but also you have to look for the prompt if the patient has any myoclonus. Sometimes the fluctuating cognition in Lewy body dementia can be mixed with some of the behavior for frontotemporal dementia, but remember, frontotemporal dementia has very early personality changes, and these are not just like having good days or bad days. These are symptoms like euphoria or disinhibition or apathy. These patients have compulsive behaviors like very peculiar eating habits and hyperorality. Patients with Lewy body dementia that get lost in their neighborhoods and have this continuous visual spatial ability is not seen in frontotemporal dementia. There's also wet, wacky, and wobbly. That's of course normal pressure, hydrocephalus, and this is a triad of cognitive changes that happens in the elderly, and you look for decreased attention, concentration, gait dysfunction, and urinary incontinence. Again, that is wet, wacky, and wobbly. The last of the dementias that is commonly tested is vascular dementia, and this is the one with stepwise decline in function. Although classically inside the hospital you don't see the stepwise decline, what you really want to look for are focal neurological changes that happen to these patients because they consistently get infarcts. It's also important to note that patients with dementia with Lewy bodies fall under Parkinson plus syndromes. The other Parkinson plus syndromes, along with the same class as dementia with Lewy bodies, is multiple system atrophy, progressive supranuclear palsy, and corticobasal degeneration. The reason why they're called Parkinson plus syndromes is because they present with Parkinsonism and a variety of other additional key features. These plus syndromes are a lot less favorable as far as prognosis when it comes to Parkinson's disease, and the classical way to see if a patient has Parkinson plus syndromes is if they don't respond to levodopa treatment. There's 3 ways to kind of categorize initially if a patient has Parkinson plus syndromes versus Parkinsonism. Number 1, the patient doesn't respond to levodopa. Number 2 is dementia progresses very, very rapidly. Or number 3, if gait instability occurs very early on in the course of the disease. As a very brief overview of the other Parkinson plus syndromes on top of Lewy body dementia, multiple system atrophy is when these patients have motor abnormalities, autonomic dysfunction, and cerebellar symptoms. They classically on MRI have a hot cross bun sign, and on pathology, macroscopically, they have atrophy. The next is progressive supranuclear palsy. These patients classically have vertical gaze palsy. This palsy is when patients have a bilateral limitation to eye movements in up gaze and or down gaze. It's usually caused by damage to the cranial nerves. On top of that, patients with progressive supranuclear palsy have postural instability, and they often come into the neurologist because they have frequent falls. The last of it is frontal lobe abnormalities, and on MRI, progressive supranuclear palsy patients have a hummingbird sign. Corticobasal degeneration is when patients have this alien limb phenomenon. They also have asymmetric motor abnormalities. The alien limb phenomenon is when patients have this very weird, involuntary, but very purposeful movement of their limbs or their hand, accompanied with a mental feeling that the affected limb doesn't even belong to their own body. Alien limb is not just special to corticobasal degeneration. Remember that patients can also have this associated with hemi-neglect, and it's almost as an aura that precedes epileptic seizures. There's a lot more that can be described with the other Parkinson plus syndromes, such as the epidemiology, clinical presentation, pathology on a macroscopic and microscopic level, but we will discuss this in another time.